Okay, we're going to be talking about burns in this voiceover. The initial management of burns really affects the patient's outcomes. There are burn center hospitals throughout the valley. I know for sure County is our burn center hospital here in Arizona. Care of the burn patient requires a very multi-professional team approach. Research-based advances in fluid resuscitation, early excision and closure of the wounds, tissue healing, metabolic and respiratory support, microbial surveillance, and infection control have dramatically improved the survival rates of these patients. So if you think of the purpose of the integumentary system and how it's the body's largest organ and it helps protect from infection or damage. So once that tissue is compromised, this patient's at high risk for having infection issues. Even with the improvements that have been done, morbidity and mortality rates remain significantly high in patients that have had burn covering more than 50% of their body or the total body surface area. Elderly patients and very young patients have smaller total body surface area, and they have an increased risk of mortality. So our integumentary system in review, our skin is composed of two layers. The epidermis is the outermost or the thinnest layer of skin, whereas the dermis is considerably thicker. It contains collagen, elastic fibers, blood and lymph vessels, sweat glands, hair, follicles, subcutaneous glands. It has our sensory fibers that help detect pain, pressure, touch, temperature. Underlying that dermis is the subcutaneous tissue and connective tissue with fat deposits. When an extensive amount of depth or skin damage from burn injury occurs, alteration of these multiple physiological functions place the patient at risk for complications. So having that understanding, the epidermis, the dermis, and then the subcutaneous. Again, just in review, the integumentary system functions. All of these listed here. Main thing, it covers our entire body. It protects us from infection. It helps prevent loss of body fluids. It helps regulate our temperature. It helps with the production of vitamin D. It helps excrete toxins or things that we don't need in our body. It helps determination of identity as far as fingerprints and things like that. And sensation reception. It's kind of like our body's warning sign if something's too hot, something's too cold. And speaking of burns, there is mechanisms of burn injury. Here we have thermal, chemical, electrical, and inhalation injury. Thermal injuries account for approximately 90% of all burns. Inhalation injury is observed in 20 to 50% of patients and significantly increases the risk of death. And for those of you that are This Is Us fans, how Jack actually died at the end of the season was due to inhalation injury. And you can usually say inhalation injury because there is smoke or black soot around their nasal passages. You can also have them open their mouth and you can see that same burning down their oral passage. I do think that thermal injury kind of is self-explanatory, but it's skin damage by contact with heat. Different sources of heat, obviously. It could be flame or fire. It could be hot liquids or alternate heat sources, stove, something like that. Something that's direct contact. Even the asphalt in the summertime in Arizona. The severity of these injuries are determined by the duration of contact, the temperature of whatever it was that caused the burn, the amount of the patient's tissue that was exposed, and the age of the patient. Heat sources that are less than 40 degrees Celsius or 104 degrees cause to burn regardless of the length of exposure, but the extent of the damage with temperatures higher than 40 degrees Celsius on direct contact has direct proportion to the duration of exposure. Things that are more than 60 degrees causes full thickness tissue destruction or that third-degree burn in less than 3 to 5 seconds. So methods of injury related to chemical injury or chemical burns. Although chemical injuries account for only a small percentage of admissions to burn centers, they can be severe. They have both local and systemic effects depending on if it's contact, inhaled, or ingested. More on chemical injuries. There's 3 categories of chemical agents. That would be alkaline, acid, or organic compounds. Alkalis, also known as base compounds. So that could be commonly encountered in the home or in industrial environments like oven cleaners, wet cement, fertilizer, items like that. Acids will be found in many household and industrial products as well. That's bathroom cleaners, rust remover, acid stuff like if you have a swimming pool and you have acid tablets to help clean the pool. And then organic compounds, those are your phenols or petroleum type products. Okay, and then on to electrical injuries and electrical burns. Tissue damage occurs during the process of electrical energy being converted to heat. This results in dissipation of heat energy and often the greatest at the point of contact or the entry-exit, which is frequently on the extremities. Electricity flows by either alternating currents or direct current. What else can I tell you? There are different voltages, high versus low voltage, and energy is converted into heat. And then AC has a greater probability of producing cardiopulmonary arrest or ventricular fibrillation from the amount of electricity that is given to a patient. Can cause electrical abnormalities in the patient's heart. Tissue damage occurs during the process of electrical energy being converted to heat. We talked about that in the previous slide. The resulting dissipation of heat energy is often greatest at the point of contact in entry and exit, which is often related to the extremities. Many factors affect the extent of injury. That includes the type and pathway of the current, the duration of contact, environmental conditions, the body tissue resistance, and the cross-sectional area of the body involved. Electrical injury wounds are extremely variable in presentation. Lightning injury is caused by direct strike or a side flash that causes the flow of the current between the person and the closest object that was struck by lightning. Cutaneous injury is often superficial because the current travels through the surface of the body rather than through it. Lightning injuries frequently result in cardiopulmonary arrest. Deep tissue necrosis occurs beneath the superficial tissue. So on initial presentation, the cutaneous wound may appear minimal or superficial. However, it can manifest as an extensive deep wound, neurological impairment several days or weeks after the injury. So inhalation of hot smoke, of chemical toxins, or of products that have a chemical component to it. Diagnosis is typically based on the type of injury, the clinical signs, and based on bronchoscopy findings. Smoke causes lung damage, as you can imagine, through the bronchioles into the cilia and the alveoli, causing an inflammatory response. Inhalation injury typically warrants admission to an ICU. We're very worried about the airway for these patients. CNS dysfunction of varying degrees. Patient can have restlessness or confusion. It manifests at a level of 15% to 40% loss of consciousness. What else could I tell you? Carbon dioxide levels can be 40 to 60%. And if the levels get more than 60%, then that is a significant finding for death. Accurate assessment and classification of the burn and the severity of the burn is crucial for the survival of the patient, because depending on that will depend on if they're a candidate to be transferred to a burn center. So it's really important that you get accurate assessment done early on for early treatment. So the classification, burn classification and severity, we need to know if it's a partial thickness, which would be a second degree, if it's superficial or partial thickness, or if it's deep partial thickness. And this slide kind of gives you a time frame. The superficial partial thickness can heal in 7 to 10 days, whereas deep partial thickness can take up to 2 to 4 weeks. A full thickness burn is considered third degree burn. This is destruction of all layers down to or past fat, fascia, muscle, or bone. These patients you have to be very cautious with. Although the area of full thickness burn doesn't have a lot of sensation, the burn wounds are not uniform. You can have an area of deep partial thickness tissue injury with nerves intact and near or right next to a full thickness injury area. So you're always going to want to treat the patient for pain, even with a full thickness burn, even if they don't have that sensation layer present. The quickest method to initially calculate the total body surface area is the rule of nines. There's a slide on the next slide that will go over that in a little bit more detail. It's the rule of nines. There's also the patient's palm method. Let me see if I have something. Palm of the patient's hand method uses the size of the patient's palm, including the fingers, to estimate measurement and represents 1% of total body surface. This method can be used for evaluation of irregular or scattered small burns. And then there's the Lund and Browder chart. So those will come up on the next slides. The body responds to major burn injuries with significant hemodynamic, metabolic, and immunological effect, so both local and systemic. The magnitude and duration of the systemic response and the degree of physiological changes are proportional to the total body surface area. Direct thermal damage to blood vessels causes intravascular coagulation, with arterial and venous blood flow ceasing in the wound area. Another important thing to be aware of as a nurse is patients that have burns, there's a significant fluid shift to the extravascular space. There's a rapid and dramatic edema formation. Cellular swelling also occurs as a result of decrease in cell transmembrane potential and a shift of extracellular sodium and water into the cell. The leaking of proteins into the interstitium dramatically lowers intravascular oncotic pressure, which draws even more intravascular fluid into the interstitium and contributes to the development of edema and burn shock. In burns greater than 20% of a total body surface area, the increased capillary permeability and edema formation process not only occur locally at the site of the burn, but also systemically. Part of the reason why we go over cardiovascular and hemodynamics at the beginning of the semester is because it all relates to the other conditions and problems that we learn about. So systemic response to burns affects the cardiovascular. There's loss of intravascular volume for major burn injury, which then can have a decreased cardiac output and oxygen delivery to the blood vessels. Activation of the SNS sympathetic nervous system with the release of catecholamines causes tachycardia and vasoconstriction, and that is to maintain the arterial blood pressure. Tissue perfusion and multi-organ perfusion are altered because of this. The magnitude of myocardial depression exceeds that which would be explained in intravascular fluid loss. Local secretion of inflammatory cytokine mediators, such as tumor necrosis factor and anaphylaxin toxins, contribute to the progressive cardiac contractility dysfunction. Cardiac instability in burn patients related to hypovolemia or over-resuscitation by medical providers causing hypervolemia or an increased afterload. Impaired cardiac function improves in about 24 to 30 hours after the initial injury. The purpose of initial post-burn fluid resuscitation is to aid in restoring normal cardiac output. So as this list goes down, we see very first loss of intravascular volume causes decreased cardiac output, and because of the sympathetic nervous system, we're having tachycardia and vasoconstriction. So we make an attempt to fluid resuscitate knowing that this cellular shift is happening, but sometimes we can overdo it, causing problems after the patient's body starts to compensate. So there is an acute phase and a rehabilitative phase. With the onset of diuresis approximately 48 to 72 hours after the injury, the acute phase begins and continues until wound closure occurs. This phase typically occurs in a burn center and may last for weeks or months. Nursing care focuses on the promotion of wound healing, the prevention of infections and complications, and the provision of emotional psychosocial support. The rehabilitative phase, the care given in the first two phases is instrumental in achieving optimal outcomes, but the primary goal of this phase is to minimize scarring and contractures related to the injury. In the resuscitative phase, we want to stop the burning process, so that's usually first responders. We want to identify life-threatening injuries. We're going to focus on ABCs and protect the cervical spine. We are going to give the patient as much oxygen as we can in case there's been any type of inhalation injury, and we will intubate if needed. We will assess the damage and circulation to the patient, assess for any additional trauma, and this is kind of like first responders triage before they get them to the actual hospital. These burn patients that are coming in to the emergency department, once the patient is transferred to the emergency department, a more thorough secondary survey is completed. Primary surveys by first responders, secondary by hospital staff. We're still monitoring those ABCs, C-spine precautions when appropriate. We're going to be doing chest x-rays. We're going to get an evaluation of the total body surface area, and then we're going to do calculations of fluid requirements. We're also going to make sure that any trauma patient or burn patient that comes in gets a tetanus shot. This slide here gives you kind of a visual as far as the fluid resuscitation or the process that's in place to help fluid resuscitate for these patients. So one of the first things that needs to be determined is the percentage of total body surface area that has been affected, and then follow these steps from there. These patients, depending on the injury, whether it's full thickness, partial thickness, these patients are at huge risk for compartment syndrome. So good assessments are crucial. Neurovascular assessments, peripheral pulses. We talk about the 6 Ps, paralysis, if there's pulselessness, numbness, tingling, pain that isn't being controlled, although that can be kind of hard with burn patients, paresthesia, paralysis, those kinds of things. Depending on the extent of the burns and locations of the burns, intra-abdominal hypertension is a big concern. If you think of the role of your skin and its purpose. Once it's injured, it has less elasticity as it's trying to heal. So that if you have fluid resuscitation or inflammation, the patients can actually develop intra-abdominal hypertension. And this is a real problem that can occur depending on if the burns happen on the trunk of the patient's body. So this is something that needs to be watched for and monitored. It can be life-threatening. Here is a list of the criteria for patients that should be transferred to a burn center. And it just kind of goes over that in more detail. Burn team members include a nurse, physicians, general and plastic surgeons, occupational therapists, physical therapists, dietitian, respiratory therapy, infection control, pharmacist, child life specialists if appropriate for children, social workers, psychologists, chaplain services, injury prevention educators, and any other physician specialties as needed. So the Burn Center provides the necessary resources to improve burn patient care and outcomes. Okay, so some special concerns or considerations. Burns, facial burns. We want to have close monitoring on the patient's respiratory status. Um, Make sure the head of the bed is elevated to facilitate ventilation and to help with edema reabsorption. Special care is taken during cleansing because of the different orifices of mouth, ears, eyes, nose. Um, all the hair is usually shaved from the wound each day to help decrease risk for infection. Once the wound is cleaned and debrided, topical antimicrobial agent is applied per the unit protocol. And because of this area is rich in blood supply, partial thickness burns usually heal quickly as long as infection is prevented. Make sure you're doing good oral hygiene. I know that all of us have had some type of burn injury at some point in our life, and it can be very painful. And again, depending on if it's partial thickness or full thickness, but these patients, the debriding process for wound care can be excruciating. So we want to make sure that these patients are properly medicated. We need quick relief. It's usually IV route. A PCA is also very commonly used. Um, and we really make sure to do this fifth vital sign assessment regularly. This is a big goal for patient outcomes that they can be comfortable during the healing process. I've already talked about the importance of infection prevention, but we'll go over it again. The goal of infection control in burns. We want to preserve existing immune defenses. We want to prevent the transmission of microorganisms, and we want to control the transfer of indigenous organisms or the normal flora for the patient. High risk of infection related to burns is if they have a greater than 30% total body surface area that has been altered. Also, development of multi-drug resistant organisms in a burn unit can be very catastrophic, and it increases the patient's risk for sepsis. So part of the wound care treatment, we want to remove any dead non-viable tissue, any necrosis. That's the debriding process. And then we want to promote the wound healing or the regrowth of those cells. We sometimes need to cover the burned area or graft the skin area as needed. So in a few slides, you're going to go over skin grafts. Skin grafts and taking care of skin grafts are very unique. You'll follow the physician's orders very closely. Oftentimes you are taking care of two sites if they have donored their own. We'll go over that a little bit in trauma as well. But sometimes you're treating the donor site and the site that's grafted to. And you have to be very careful. There's very specific phases of that graft and wound healing. Usually the donor site's very painful The healing process has a lot of itching. You have to handle the tissue very cautiously. You can poke a hole right through the graft tissue and cause injury to the wound that's trying to heal. You can read over more in the book in chapter 24 about wounds and burns. But there is a whole process. If you ever have an opportunity to go to a burn unit, it is fascinating. The temperatures in those units are kept usually fairly warm as these patients, um, they can't thermoregulate, so it's usually kept a little bit warmer. It's a very sterile environment. The debriding process is very extensive. They use hydrotherapy a lot to help with those wounds, and then silver-based agents. Um, and then there's an open versus closed method. Open method, the burn wounds are left open to air after the microbial agent is applied. It provides increased wound visualization. It eliminates dressing supplies. It improves joint mobility and allows direct contact between the wound and the environment, increasing the risk of infection and hypothermia. The open method is commonly used on superficial burns to the face. Then there's the closed method. It's a gauze dressing that's placed over the antimicrobial agent after it's been applied, or the wound is covered with gauze dressing that has been saturated with the chemical or the topical antimicrobial agent. The closed method reduces heat loss and pain or sensitivity from the wound exposure, and it assists in protecting wounds from external mechanical trauma. Discharge planning must begin on the day of admission. Assessments are made regarding patient survival, the potential or actual short-term or long-term function or disability secondary to the burn or non-burn injury, financial resources available, the family roles and expectations, and then, of course, the psychological support systems necessary for these patients. Nurses play an important role in the multi-professional discharge planning by providing the patient and family education, also evaluating the need for additional resources to meet the patient's long-term rehabilitation or home care requirements.